This week, I would like to discuss issues surrounding end of life issues, those issues of euthanasia, voluntary assisted death, withdrawal of support, relief of suffering, medical assistance in dying. What do these mean, and is there a difference? And what does the church support? I would like you to contemplate the following real world case from my personal experience as a critical care physician while you listen to the rest of my video discussion. An 18-year-old college student arrives in the emergency department in severe meningococcal sepsis. She's in complete respiratory and cardiac failure. She has been placed on full life support. She has a 20% chance of death, 100% chance that both her arms and her legs will be amputated as they are gangrenous, and she has a 30% chance of chronic renal failure. So the question is to ask yourself, is this case rare? Is this care extraordinary, burdensome, or dangerous? Am I within church teachings to give the family the choice to withdraw care? Do I have a duty to discuss withdrawal of care? Should I or the family make this decision? Canon 2277 clearly states that any act or omission that is intended to cause death is morally unacceptable. So euthanasia, voluntary assisted death are both unacceptable according to the Catholic Church by moral standards. However, withdrawal of support and relief of suffering come under Catechisms 2278 and 79, and they allow for removal of support which is extraordinary, burdensome, or dangerous, and it allows for relief of suffering, even if it will shorten someone's life, to support the dignity of the human being. That leads us to a very weird and unique get around called medical aid in dying. As a workaround to the active involvement of a physician or healthcare worker in the death of a patient who is considered terminal, Canada and 10 U.S. states have adopted medical aid in dying laws. These require two physicians to certify that a patient has 6 months or less to live and that the patient is able to self administer a lethal amount of drug which has been prescribed by a physician. These laws are crafted under the uh, guise of relief of suffering, relief of pain, in order to help the patient not suffer anymore under a condition that is thought to be lethal. We will be discussing this and its relationship to withdrawal of support and relief of suffering during the withdrawal of support with a critical care surgeon who has dealt with literally hundreds of patients in this situation in the surgical ICU over 30 years. Dr. Barrow, we were going to start someplace else, but as we were talking before we began this video, you mentioned that this was a timely subject. Why do you consider this a timely subject?
We recently had an elderly patient who had a disability his entire life. He had a underlying mental and physical disability. So he basically spent his entire life in a nursing home. A great nursing home. He had a family that loved him, but they couldn't care for him. He was nonverbal. He couldn't walk. But he grew up, 80 some years basically like this. Can't eat, can't walk, can't talk, can't feed himself, lays in a bed. He came in recently. His nursing home that has had him forever closed down, so we had to go somewhere else. And since then, his elderly siblings, which they're all getting old, are just so distraught with the care that he gets there, and it's just not the same. And he can't do anything, and he's just getting bed sores, and he's getting sicker and sicker, and he keeps ending up in the hospital. So we ended up on a breathing machine, and his family came in and they said they would really, really like to be able to withdraw care. Just let him go. Let him die peacefully. They wanted to be with him, they wanted to be there, but they just didn't want to see him tortured anymore. They didn't want to see him what they felt was in pain. They just said, let's just take the breathing tube out and let nature take its course. If he dies, then, thank God, basically.
So he had required artificial ventilation.
Yeah, he
Okay.
was so sick at one point, we put him on a breathing machine. So we didn't want to take the ventilator off until we knew whether or not we'd have to put the ventilator back. So if he fails, do we really have to put this back in, give him a trach, put his airway here? He already had a feeding tube because he can't eat. Apparently, in the state of Pennsylvania, a beating heart is better than no beating heart. And because he had an intellectual disability his whole life, he couldn't possibly have told his family what his wishes would be. So they were not allowed to make that decision for him. So we had to do everything for him again and again and again. It was one of the saddest things I think I've ever seen.
So you had to do what we would call in our theology approach to this, or even philosophy, extraordinary means. People aren't born with a piece of plastic sticking out of them,
Yeah.
connected to a machine to breathe, but you were essentially forced
To
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 keep
torture this
him
man,
alive
to
with a
do
breathing machine.
right. And these are painful procedures. I think a lot of people say, well, it's a simple tube, but
It's a tube, but
uh,
if you can move, you're going to want to pull it out because who wakes up with a piece of tube shoved down their throat and doesn't reach for it? So now you're tied down, and that's reflex. You can be very, very poorly, badly injured, and still reflexively want to pull that out. So now you're tied down. So now we're breathing for you, we're feeding you, and we're turning you back and forth in your bed repetitively as you soil yourself.
so we might almost consider this that the state is mandating that we torture people at
Well,
some level.
it sure did feel like it that way, and it
Uh,
sure did feel like it to the family.
so let me turn this around to the actual withdrawal of support in someone. Um, and I want to ask you a couple of questions about deciding, end of life. Like, how soon is someone going to die? A lot of laws out there say that we have to be able to predict within 6 months that someone's going to die. In 30 years of doing this, how often are you correct when you have to think out 6 months?
No way. People don't know it's 6 months. You don't know if they have a different injury or different disease or a different process that happens in that 6 months, separate from the one you're just dealing with. I think end of life things are closer closer timelines.
What would you
Two,
think would be a timeline where you feel relatively comfortable in your medical experience to say, I might be off an hour or a day, but I'm not going to be off months.
I think it's kind of situational. I think there's some things, when you're 98 and you have a broken neck and you're going to go to a nursing home with a collar, statistically speaking, you're not going to live 3 months 98% of the time. Disease states, if somebody has perforated bowel and they're septic and they're 90 and they're in renal failure, without extraordinary measures, you're going to die in a couple days, if not hours. So I do think there's a little bit of a situational process to that, but I think for most of us, it's a couple weeks. Like you don't know what's going to happen 6 months from now. Once you don't have any idea. That's impossible to know what
So
six
it
months
would
time
it
will
would
bring.
seem to you ridiculous as a physician to say I have to predict within 6 months.
Right, and oddly enough, back to this case, they told us that the only way that we could get around this was to have an ethics consult here, and the ethics team came up and said, "Does this patient have a terminal condition?" I said, "Life is a terminal condition. We're all going to die."
Yeah,
It didn't go over well.
imagine
Their
it didn't.
idea of a terminal condition was a cancer. I said, "Well, not all cancer's terminal. So how are we using that as a marker?"
Right.
I can tell you, this man has terminally no chance for any quality of life, and he's going to keep coming back to the nursing home every couple weeks to get his process repeated. Um,
And at a level one trauma center, even a gunshot wound to the heart may not be terminal.
right. So, but
so, so if I want to ask you, but when we do withdraw support on people who are, let's say they're on massive doses of medications to keep their blood pressure up, they're on a breathing machine, you know that every time you turn things down just a little bit, they begin to crash, and we want them to not suffer when we
correct.
start reviewing that. How do we avoid crossing the line between relieving their suffering and expediting their death? In other words, pushing so much medication that it actually causes the death. Are there
Well,
things that we do, like whether order sets that we have or something like
well,
that?
we have order sets, and we follow physiologic parameters. You have an order set that says, as someone is resting comfortably, comfort measures. If you notice that their heart rates are spiking, their blood pressures are spiking, they're grimacing, they are restless, they're breathing really fast and what we call guppy breathing, that panting.
Hmm.
Um, There's doses of medicine that are realistic with people who are alive. That's not going to kill them, just for comfort, to make them a little bit more comfortable based on these physiologic
So we
parameters.
try to put some science into this so that we are providing relief of suffering without performing euthanasia.
Correct. We don't enhance people's death. We make their
Mhm.
death a natural, easy. Actually, easy is a bad word, but we try to make it as natural as possible and make them as comfortable as they can be. And, let's be honest, we're treating the family sometimes as well. I mean, who wants to sit there and see their loved one gasping for air after they've made these decisions? So, yeah, it's within the parameters of physiologic comfort, but it's not euthanasia.
So, as a final question, uh, this video is going to be seen by people who are training to be theologians. They're going to be working in ministry. Many of them will be going into hospitals and helping people through this process. What do you think they need to know about supporting a family through the process of deciding about withdrawal of care?
I think there's a couple things. I think one very important thing is that families realize they are speaking for their loved ones. Listen, when you ask a family what they want, they all want their loved one to stay alive, right? Nobody wants to say, I want them dead. Um, they want them alive, but they realize that in certain circumstances, that's selfish. Selfishly keeping their loved one alive for their benefit and not for their loved one's benefit is selfish. It's just there's no other word for it.
So have them
So
focus on the individual, not
what
on
would
their
that
feelings.
patient want? What would your
Yeah.
family member? What would they have liked to do? Would they like to run or jog or eat or read the paper? Well, they're probably not going to be able to do that anymore. They're going to have to go to a nursing home. What would they like? What did they like to do? What would they have wanted in this circumstance if we knew this is going to be the outcome? What would they want? So I always like to make sure that people know they are speaking for their loved one, not about their loved one. They are the voice that is behind this. They are essentially that person's living will, right? Living will is a piece of paper. You are their living will. You know them. You know what they would want. You know your family's values, what that person would want. I think that's important to make
So,
people,
as with the way we treat patients, that relationship is incredibly
yeah,
important. That's where it's got to start.
yeah. And I think it's to get people to understand that, again, they're not making this decision in a box. They're not isolated. That there's a lot of evidence that goes behind the thought of talking to someone about end of life or withdrawal of care.
Well, I thank you very much, and I thank you for being my partner for so many
Oh
years,
gosh,
and we've shared a lot together, and I think this will be very instructive for people. Thank you very much.
sure.
Returning to our contemplation case, I decided that although I had no medical duty to discuss withdrawal of care, that the treatments we were giving this young woman were extraordinary, incredibly burdensome, and in many cases dangerous. It had serious side effects. And given the dignity of the individual, the church allows me to discuss withdrawal of care in these situations. So I decided to discuss this with the family. They prayed about it. They thanked me for telling them this because no other physician had. And 4 years later, they came back and said I was the only one to have honestly told them what to expect, that everything I said had happened, purely luck, I suspect, and that they were glad to have had the choice. But knowing their daughter, they felt that she would want to go on, even being severely debilitated. And certainly she did. She became a physical therapist and now works with double and triple amputees in her professional life and is a wife and a mother. I can do all things in Him who strengthens me.